Yeah, good afternoon, everyone. I hope everyone's had a nice lunch, and we're going to continue this great day with a discussion regarding the most common questions that are asked by patients when they're in clinic. So let me introduce our esteemed speakers with you. We have Dr. Fernando
Rivera.
I've gone blank.
Rivera.
Rivera. And how dare I go blank? I apologise, Dr. Rivera. Dr. Rivera is from the university, from Toronto General Hospital, and cardiologist. And then we have Dr. Victor Sapira, and he's with the University of Calgary. And last but by no means least, Geneviève Maté from CHUM, Montreal. So let's perhaps just go straight to some of the questions that we do have, and start with the first one. From a cardiology perspective, what are the most common questions that patients ask during their clinic appointments? And I'm not asking any one of you in particular, so I won't pick on you unless you're too quiet, and then I will pick on you. So whoever feels free to kick that off.
So let's start with the cardiologist.
Okay.
Yes, I think that'd be
Okay,
fair.
Fernando
I
Rivera.
think that's fair,
remember
right?
that.
No, thank you for the question. And I think that it depends what kind of questions we get, in depending on the journey of the patient, right? A lot of what we see in patients that are already diagnosed and already being treated, and I think we have been speaking a lot about the initial steps, getting in the medications, getting the start the treatment. Something that I see a lot more in the later phase when patients are already being treated is about their symptoms and about their day-to-day life, like what kind of intolerance, the reason of the exercise intolerance that they have, how they can improve their symptoms, a part of what the things that they are doing. I think that's something that we hear a lot. Something else is how we interact as clinicians in the care of these patients, how we interact. There's a lot of questions that might be directed to all of us, but I think we answer portions of the questions to patients. So I think a lot of what I hear is what can I do to feel better, a part of the pharmacological therapies that we receive, and what other strategies outside of what we know of the standard treatment are available.
Yeah, so I'll echo a little bit of that. And the patients that we see, so I'm a hematologist in Calgary, and I get to see a lot of patients that might have either the possibility of light chain amyloidosis in the heart, so might have a precursor condition of myeloma and amyloid, but with a potential transthyretin amyloid more in the heart of the nerves, and that's patients that do have MGUS, that might have MGUS means a monoclonal protein, whether it's blood, urine, but that do have more symptoms of potential cardiac amyloid of transthyretin origin. So those are the type of patients that I have. So when they come from the cardiac perspective, they might ask questions about what is that I have, what are the tests that are needed. They will tell me what the journey has been and what the main symptoms that are actually more worrisome for them. And the other thing that they have is questions about amyloid, because someone tells them that you could potentially have amyloid, I will refer you to this doctor. And sometimes they go referred to the heart doctor first, or sometimes they get referred to me first. Or we have a central system that we try to kind of send to the most appropriate in terms of what is needed. But then patients do have questions about the journey and then what comes next. So sometimes we have answers right away, sometimes we don't have answers right away, and we just explain to them what are the things that we're worried about and what are the things that we have to work on and go from there. But obviously, we all have to work on supporting the organ that is affected. In this case, from the heart perspective, is how can we manage the heart failure of the symptoms that they have. And that's what we can address on the initial visit. But in terms of answers, sometimes the first visit might be just the one that we just introduce all the tests that are needed, how they are needed, and then elaborate a little bit more about how the journey has been and learn from that. Every single patient is just seen us from the first time, so we don't know how they've gone through, what is the social support and other things that have to do with how we're going to manage the disease that they're starting to battle.
Yes. as a neurologist? Do you
I
want
was
to
just
hear
going to
this?
say it, but we can do all now from the neurology
Yes.
point of view perspective. What do you find are the most common questions that you find you're asked in clinic?
So often I'm asked, well, why did my cardiologist or rheumatologist ask for a neurologist to see me? So sometimes patients have truly no symptoms, and this is most often the case with the ATTR patients, and especially those with genetic forms. And the goal is to determine if there's evidence of polyneuropathy, because then access to some treatments like the silencers we've been talking about is heavily driven by meeting a neurologist and documenting polyneuropathy. For the other ones, they have symptoms we think we can help with. And that's what patients are often wondering, well, how is this going to progress? This numbness in my hands and my feet, does it have anything to do with my amyloid or treatment, for instance, in multiple myeloma or AL? So that's my role to tease that out. Patients are worried about progression of disease, what to expect, so we can guide them with that from a neurology standpoint. And also they wonder how can they cope with their disability or symptoms. And we have a toolbox in neurology for difficulties with ambulation, neuropathic pain, for instance, and also a preoccupation, what can I do to keep myself in shape or prevent, delay complications as much as possible.
Do you find though when patients are first diagnosed, they're so overwhelmed that perhaps in the first couple of visits they don't really ask anything because this word amyloidosis is very, they haven't heard the word before. They then find out all these horrible things that amyloidosis can be in some cases. But do you find that the questions usually come after the first couple of visits or straight away on the first visit, or is that dependent on the patient really?
And well, at least from my experience, it depends a lot of where the patient is and what stage of this journey, like from the initial thought of somebody thinking in amyloidosis and start investigating. Sometimes if we see the patients at that stage, they want to know what they have, right? So I think a lot of the questions are more directed at what kind of disease, how are we going to deal with this? What is, and that takes months, right, sometimes to get to the proper diagnosis. And once that we are there, there's other questions that will arise, like what are the next steps? What are the treatments? What kind of side effects can I expect? How is going to be the prognosis? So I think that we as clinicians, we need to be very mindful to understand where the patient is. Because as you mentioned, there's always a lot of overwhelm, there's a lot of information that sometimes we throw in once, and it's very hard to actually digest and to process. So I think it's a stage thing that we will be even answering unasked questions, right? We know what kind of questions there might be, worry about prognosis, about if there's hereditary with a role in the family, who need to get tested. So I think we need to think in those questions with each patient, depending where they are, so at least we can help them to ask the questions that they might need.
So basically, so what you're saying is it's really a process depending on the patient, right?
Yeah. And considering that these questions, just answering one question, we can dedicate like a full half an hour, right? And sometimes we don't have the privilege of time, nor the patient, neither the clinician. So I think that's where the stage part to go address it step by step. Let's go to where we are now, and then we start understanding the little parts of the process rather than just trying to show the whole journey in one consult. That will be extremely overwhelming.
Yeah, for sure.
So I think the first visit or the first couple of visits are always important, because that's when we get the sense of who they are, and they get the sense of what we are and how can we help them. And that varies depending on what they have, what the symptoms are, what the concerns are. The psychosocial part sometimes is really hard to grasp on the first visit. So when we talk about treatments and what it implies, that means that they have to come to in my case, that treat more like GN amyloid. they come to the cancer center and there are side effects with treatments and stuff. So obviously it's expected to be overwhelming. The first question that I ask my patients is, how much do you know about this and why you're here? What do you know about the reason for this referral? Because sometimes people say, we just find a protein in the blood and we want another doctor to look at it and see what this protein has to do with the heart or with the kidney. So every single patient may have different concerns on the first visit.
Yep.
And then the second question is what is needed for me to understand what this disease or what is concern that my other doctor raised to, and how can I actually take care of this and know what to do.
Mm-hmm.
And then that takes a little bit of time of knowing what it is, how much they know, and everyone is going to be a little bit different. But even if we have the diagnosis and we have to talk about what this condition is, it's overwhelming for them as it is for many of us. And in hematology, explaining amyloid to physicians is also challenging. It's not something complex. When you talk to people and say, you've been referred to me because you can have amyloid, and amyloid is 42 different proteins that can mimic the same, so that's very complex to start with. And then people might be really overwhelmed just by knowing that there might be 42 different things that can happen or be related to the same thing, and there is a lot of uncertainties. So you get to know them as you go through, and every single patient might have more concerns. There are some people that the main concern is like, I'm feeling unwell, help me.
Mm-hmm.
Some of the people might want to know more about what they have or what is needed to understand what they are going through.
And then let's go on to the next question. And the next question basically is, how do the common questions get addressed within the broader healthcare team? In other words, do you have dedicated nurses that perhaps can speak to the patients after the initial visit? Or do they speak to the patients later on? What kind of systems do we have, or do we not have, or what would you like to see?
Yeah. In our center, it's mainly the cardiology nurse, I think, was the main point of contact for patients. For the other ones, we had tried to find some time from other professionals, but truly a case manager would be ideal for patients with multi-system involvement, which is not, that's a wish I'm putting out there for us. But for sure, repeated questions, development of patient or patient information documents would be most helpful.
And I think how I deal with this is always very complex, right? Because there are many questions that we might not be the best person to answer. So I always try to encourage my patients to have an open line of communication with their different clinicians, right? Because we are talking that sometimes might be a nutritionist involved, might be already a psychologist involved, might be a cardiologist, a hematologist, a neurologist. And I think that in those kind of things, that when the questions come into the clinic, it's like, okay, this is something that you need to ask your hematologist. And I even help the patients to kind of understand how to ask this question, where to lead the question directly. That sometimes helps. And at least when we work in a big team, I respect the opinion of the other clinicians, right? And I think sometimes that can be a confusion, that everybody's trying to answer the same questions. I think sometimes we need to be able to say, I'm not that person to answer these, but this is what I will recommend you to ask, and I think that might help as well.
Yeah. I guess that brings us really to the next question. How do we avoid duplication or contradiction in terms of the information, in terms of the information that we have?
Yeah, so that's always a good question, because sometimes the main thing is maybe all the doctors are saying the same, but they're saying the same in a different way, and the patient might get a different perspective of what someone says in a different way. So what I usually do is I tell them, what did doctor say to you? What happened with the last visit? And we try to elaborate about things, because we get notes and we might have a more medical idea of what happened in that visit, but then we always wanted to know what was the understanding from the patient. And sometimes the problem is more the communication part of things and the interpretation part of things that we might have to work on. And it comes to these kind of filters that we have. So my nurses, and I gotta say thank you to the nurses for all the things that they do. They are the primary care, so they are the first people that see these patients when they come into the clinic. They do the vitals, they talk to them, they assess the psychosocials. We have these surveys or questionnaires that are trying to address not only the medical part, but also the psychosocial issues, and that's always important. So by the time that we show up, we already know of, have a pre-screening of what they truly are suffering and what is the most important thing on that particular visit, rather than just talking about side effects. But sometimes it's the things that we don't see on that visit, is what the issues are to get into the cancer center, the transportation, arranging people to come to have, they feel even before coming to us. Sometimes patients come to us and they tell us as much as they want us to know. If we say, you know, you have a good response, they immediately shut down and say, oh no, all my concerns might not be valid because I'm good, so I might get better. But there are some other people that have so many concerns that are more obvious and might be more keen to show or share those with us. So it depends on also patients' personalities and how open they are to speak with us. So we have the benefit of nurses that are way more sensitive than me, and they get those kind of concerns laid out usually on the first kind of interaction. So by the time that I go there, I try to elaborate on the things that I think are more needed in that particular visit, and that can change from one visit to the other.
And then, based on common questions asked by patients, what do you feel are the patient's greatest concerns?
When they come to neurology, I think it's a lot of the loss of independence. So how can I be able to remain independent? So we're in a good place right now because of treatments in genetic cases. And it's teaching, well, and other patients who come, patients with ATTR wild type are often elderly, and other things are coming up with age. So, well, you know, your back pain, you can get injections for that, or your foot drop, we can get you a brace and teach you how to walk with it. So these are important things, and all sorts of ailments that are tricks we learn about and can help with.
So that's the same. The concerns may vary from patient to patient, but one of the main concerns is, getting this sense of independence. People, as we get older, the type of disease that I see more, the light chain amyloid, is something that occurs at the age of 68 years as kind of average age in my patients. So at that time, there are concerns about how can we get into the clinic, get the treatments done. But obviously the acute concern is, I have this symptom, my heart and my kidneys are the ones that are failing, so how can I get better? I'm swollen. This treatment is giving me these side effects, how can I make them better? What is needed? So every single patient might have different side effects that we have to work through. Every single patient might have some psychosocial issues that we have to learn from throughout the journey. Sometimes there might be more that might be more obvious in that particular visit, and then those ones might get better, and then the next ones might be something different in the next visit. So those things actually change from time to time, but it's important to recognize them.
Do you find it from a psychological perspective that a lot of patients do suffer psychologically from hearing that they have something like amyloidosis? And do you think they're very open with, for example, yourselves about how they're really feeling, or do you think most patients internalize that and don't really talk about it?
Well, I think that we need to recognize that any person dealing with a medical condition, acute or chronic, will be dealing with a problem and will be internalizing some of the issues, right? I don't think anybody that is dealing with a disease is completely fine, right? So I think we need to directly ask how they're feeling, right? How we can help, because it's not just managing symptoms or managing the disease, we're managing the person, and there are resources available, and I think this is something that we need to let them know, that it's normal to feel overwhelmed, that it's normal to deal with these issues, and there are all resources available. And I think that's where it's not us solving the issue, but it's facilitating the patient to receive the adequate care that they need. No? We're working, for example, in rehab, that we have resources. It's one of the pillars of cardiac rehab because we try to give all these elements and to see the person in the center and say, okay, we are going to manage the medical, the psychosocial, the nutrition, and all these different aspects. So I think it has to be part of our clinic. We need to be ready to provide resources to all kind of patients. We need to have the resources first, right? But we need to find ways. There's always resources in the community, in the academic hospitals that will be available as well for that.
Okay. And then, as physicians, how do you prepare or adjust when you identify questions consistently being asked by patients?
How do we prepare?
Difficult one, yeah.
Yeah. So you know, as much as possible, we try to go through every single question that they might have, and if there is one that is just repeatedly coming over and over, then we try to elaborate more about why this is an issue that for you makes a little bit more sense to discuss every time, and then try to get it addressed. I think the psychosocial and the spiritual part that we talk about is the one that we're not really good in terms of being doctors at getting a good sense of what they are. It depends more about how much patients want to express to us and how much we try to elaborate on those things. So what I usually tell my patients, especially in the first visit, is like, you know, the psychosocial, the spiritual part is as important as the medical and the supportive care management part is for the people with a multisystemic disease, as it is like amyloid. And we have psychosocial issues that essentially might not be discovered until the patients tell us otherwise, or we see that they are dysfunctional in a way, so it can take actually longer before we recognize that that's an issue. But we always tell our patients that, you know, these issues are recognized. We know that you're dealing with something that is important. How much you're going to be coping with that by just internalizing or hiding that in a part of you is something that varies from patient to patient, what personality, what systems they have to cope with that. But we tell them, you know, this is an open invitation. If you don't think right now you need to talk to someone, sometimes just talking to someone that is not your family helps more. Because patients sometimes don't want to talk to family members about how they feel because they don't want to pass that burden into the family members. And they just keep it for themselves. And sometimes just by talking to someone that is from psychosocial and getting to realize from them what they truly need helps more than truly saying, this is the way I feel. It's just giving a little bit more time, think about it. I'm going to give you this. In my center, we have a brochure that essentially tells you that these are the things that you have to do. Everything starts with a conversation on the phone, and we can decide from what you have, what can we do to help you.
Yeah, so in other words, what you're saying, Dr. Cepeda, is that the guilt complex. So they feel guilty that they've got this disease. They feel guilty if they were to ask their caregiver.
The problem sometimes, like if you come with a heart failure and the main issue at that time is trying to get better, trying to decrease that swelling that you have. So the other part, yes, is important, but they want to feel better first before they can address the other one. The problem is that sometimes the two of them might have to be treated at the same level at the same time. And sometimes we just, patients and ourselves prioritize more in one versus the other, but the reality is that every single part on this big burden that we described related to the diagnosis of amyloid affecting different organs, the psychosocial involvement is also quite deep. So those are the things that we have to work as a group. Sometimes the problem is that we don't really have graded resources to deal with all of them in the same way in different places. But if we don't recognize the problem, we're not going to start working on the solution.
Yeah. And then in terms of caregivers, do you find caregivers ask the same type of questions as patients, or do caregivers normally ask you different types of questions?
Some are similar in terms of progression, what to expect. It's always tricky, however, you have to make sure with the patient they're at ease of hearing it. So we see this sometimes, patient not being too keen on knowing what's next. So we have to take people apart for a second. And most caregivers want to know how they can help. And that's great to have them on board for as a team, as the caregiving team.
Yeah, it's good to have the extra support there. Yeah.
I think it's I love when somebody arrives with somebody else, with a caregiver, because when we're providing a lot of information, it's very hard for somebody to process everything at the same time. So it's good that in the next visit, the caregiver is like, okay, I still have these questions. They arrive and they help the patient to deal with the things, and so the burden is divided. So I think that's a great tool. And even when we're providing recommendations about management of symptoms or diet, those kind of things, is good when we have not only one person, but the two of them. They can say, okay, yeah, and sometimes the changes that we need to do involve the family as well, right? So if we're recommending to avoid sodium intake, for example, and in house everybody, eats a lot of salt, it's not fair for the patient. So we need to make sure that everybody is involved in a lot of these things, right? So not always is possible, and not all not all people have the advantage to have somebody in their corner, that we need to see that if they don't, so at least we can help also addressing those kind of things.
Yeah, so the caregiver is a very good thing to discuss, because obviously the caregivers are doing things out of love. So they want to help the person that is dealing with a very stressful disease, and they do as much as they can to make sure that that person gets the best care for. And they're lovely, they do a lot of things, but they also get burned out with all the things that they do over time. And sometimes we tend to just recognize things more from the symptoms perspective and patients and other issues, but the caregiver is really important, because that needs to continue caring for people for life, right? It's an investment. It's someone that I love, and I will love you forever and ever. So sometimes getting to recognize that the caregiver is also suffering is important, because I said my patients, with this psychosocial issue is not something that we offer only for patients, also for people that are working on the care of my patient is important, because I want to make sure that you're okay to continue helping. Mm-hmm. And sometimes the problem is that we don't get to know much of that unless people are really willing to express that to us, and sometimes it's difficult to get it. Personality might be one issue. Another thing is patients are super nice, and even caregivers are super nice to us. They don't want to spend more time with us, that more than is needed or they thought is needed, and they say as much as they can. But sometimes that's also important. If there is any caregiver here, it's also important to discuss with your doctors, because we know that you go through the same with them, and sometimes even more than what we see.
And then, just to change it a little bit, what have you learned about amyloidosis patients based on the common questions that they often ask?
I'll let someone else start. Yeah.
Well, I think I have learned a lot. A lot of my journey in amyloidosis, and a lot of the learning that I have had, is coming from the patients, to understand their needs, to understand their concerns. And that's how we prepare to see the next patient, right? Because now we start understanding what the people is dealing with, then we can start focusing in those things as well and not forget them. So I think I learned personally a lot about management, about their own psychology behind the disease, that goes beyond a lot of different other conditions that we see, that there more be given medications, managed, and things improve when we have so many comorbidities, so many issues, and so many healthcare providers involved in one patient. So it teaches a lot of how we need to approach, how we need to consider the other healthcare providers, how we need to communicate between us as well. That I think that's one of my biggest lessons, is that in this kind of patients, we need to communicate to other healthcare providers to make sure that we are united front and that we're working in the same path, and the patient feels that as well.
You want me to say something? So I can tell you that I learned everything about amyloid because of patients. So I did my training here in Toronto, and one thing that I was told to is you're presenting this project. If you go to that meeting, and we can give you some support from patient support group. And then the only thing that you have to do is when you're back, you present back to the patients about what the news are. And then when I went to those meetings, I realized of how much of a struggle patients have. And one of the first questions that they asked me, you're going to continue working on amyloid because we need doctors. We don't have enough doctors. And that's true. It's a rare disease. That is something that people are not familiar with, and that's something that sometimes is really hard to find someone that has invested time, efforts in trying to offer patients. At that time, there were not many treatments that we have available. As you can see, cyborg was recently approved, and that was the first treatment ever approved for amyloid. Before that, there was nothing. We just borrow treatments for myeloma. But that just tells how much patients actually really have needs and the struggles that are not yet to this point fully work with, and that's something that we have to continue learning. So every single patient is a human being that will learn how they're coping with the disease and try as much as possible to support them. So anything that we do these days is because of all those learnings on how these patients have to go through see more than 3 doctors before they're diagnosed, and it takes more than a year in 1/3 of our patients. So that tells us a lot, and that means that we have to work more and do things to try to close the gap as much as we can.
Mm. Yeah, I feel patients need experts, reliable sources of information, because amyloidosis well, you probably trained more recently than I did, but back in the days, amyloid, oh yeah, it's on the differential of many things, and it's sad. People die quickly of this, and there's nothing we can do about it. And that was the end of the story, but that's very different now. So we're fighting, and patients need doctors who are knowledgeable about the disease, that can answer their questions, and they need the feeling that all the healthcare professionals are working as a team, and that we actually talk to each other. And I make sure I mention it, like this is the letter, and for some reason, some physicians, some of my patients are followed in another institution for other specialties, but just make sure everything goes out to the other physician so that it's all followed up together.
That's great. Something that I've come to realise, just having listened to the 3 of you speak now, is that you don't look at a patient as just being someone who needs a pill to get better. You're looking at the whole patient, which I think is a change in terms of years gone by, where you used to visit the doctor, you'd get a prescription for X, Y, Z, and that was the end of it. We never really had the psychological approach and the health and the other help that's available out there. So that's fabulous to see that change and shift in terms of the medical community. And we do, trust me, the amyloidosis community do appreciate all that's been done by yourselves.
And just to echo that, but in reverse, we also appreciate what you guys do for patients themselves, because talking to each other actually makes the process much easier for us. Because it's really hard for us to sometimes tell you this is what you're going to go through, because we haven't gone through. So we do it, we tell patients what to expect, but then learning from another patient that has gone through the same always helps them. It makes it feel that they're not alone, and that's very important, and you guys have done tremendously well at doing those things, and thank you for that.
Thank you. And you touched on something very, very, very dear to my heart, and that was when I was first diagnosed. The only way I can really describe that was I felt like an island. I felt like an island. I was out there. No one knew anything. We had nowhere to go and nothing to do. So as things have changed over the last 9-10 years, it's been fabulous in terms of the therapies that are out there today that were not available then because it was symptom management or liver transplant in 2014, 2015. So things have changed tremendously. Mm-hmm. And on that note, I think what we should do is we should throw it out to the audience. Mm-hmm. And I'm sure there may be 1 or 2 questions, but maybe not. They're so shy. I don't think they'll ask us anything. What do you think?
I'm being grilled on other diseases for at least 2 hours every 6 months, like on web. So I'm ready. Bring it on.
Any questions? Thank you, everyone.
So maybe
Thank
all
you.
the questions were asked with regards to...
Yeah.
Yeah. Okay, thank you very much.
Thank you.
Thank you.